Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am joined again today by the amazing Dr. Morgan Camp, who has been very generous with his time and has agreed to walk us through a whole series of amazing topics that we're going to cover. If you didn't listen to the last interview that we did with Dr. Morgan Camp, go down and find that interview. That will give you a really good overview of just him and how he practices medicine. He has been practicing medicine for well over 20 years. He has a special interest in functional medicine, and he's expanded his practice to include and work on the deeper aspects that bring us to the root cause of our illness. So he's really big into the mind-body wellness, energetic medicine, and healing with consciousness, as well as all the amazing latest research that's coming out, whether it be peptides, senolytic cells, Senescent cells, all the sorts of amazing things that we're going to talk about today, and things that lots of practitioners are overlooking. So he's well and truly up to date with the latest in what is going on. And as I mentioned last time, he's what I would call a true healer. He's got his very left brain scientific mind, but he's also very intuitive and really good at tuning into what's really going on with people, which I think is always the perfect combination if you're looking for someone that I would call a true healer. So welcome, Dr. Camp, and thank you again for joining me. I'm always very grateful to have you on board.
No, thanks, Fiona. My pleasure. Yeah, this is good. It allows me a chance to review my research and learn how to, just express some of these very complex terms in ways that your listeners and my patients can understand. So it gives me just a chance on how to meditate on how to take overly complex things and hone it down to what's the essential of them. And this is a fascinating topic. I just got back from vacation and I was staying with a friend of mine who's a chiropractor, and was just briefly telling him about senescent cells and was telling him, how they work. And he goes, "Oh, those are just like zombie cells, huh?" And I'm like, "Oh, that's the exact term that, scientists are using for these." So maybe that's a good introduction. So, so I'm just going to try to, today's just a kind of an intro on the topic. We're not going to go too deep. And if anybody has any questions on this that would like answered in future podcasts or calls, please let me know, or let Fiona know, and we can go from there. That'd be great. And, but, first question we had today was, what is senescence and senescent cells? So, it's really simple. They're basically cells that have stopped dividing. So we all have cells. So all of our cells divide, but why don't we grow larger? So like you think really simple terms, why don't we keep growing bigger? Well, I mean, so a lot of people are now, but okay, assuming you're eating a good diet, why don't we just keep growing bigger and bigger? And it's because our cells stop dividing after a certain number, and then they go through what's called, we have in our cells, we have something called apoptosis, which is a programmed cell death. And then we have autophagy, which is programmed cell repair. And so senescent cells are basically cells that have divided to the point where their telomeres are so short they can't divide anymore, and yet they don't undergo apoptosis nor autophagy, which means they basically have a lot of cellular damage, more than likely, and they are not really fulfilling any useful functions. And they are really at a sandwich point on all illnesses. So, almost all research on chronic age and chronic illness and aging now is showing us that at the root of almost all aging and all diseases associated with aging, including diabetes, kidney disease, heart disease, osteoporosis, lung disease, lung fibrosis, emphysema, all of these have underneath it the root of them senescent cells, high number of senescent cells, and also hyperactivation of what's called mTOR. And that's a topic for another conversation, but those two go hand in hand and are interrelated, because when mTOR is too active, that means you have less of what's called autophagy and cellular repair, and therefore you get more senescence as a consequence. So again, those senescent cells are cells that have reached a point where they're no longer dividing and no longer able to divide. And they are naturally occurring. We should say they're naturally occurring at all ages of life. They are important. For example, in childbirth, senescent cells are believed to be what's actually helping lead to the actual delivery of the baby and dilation of the cervix, et cetera. I won't go into those technicalities, but yet they are useful roles, and they are also useful in preventing certain types of cancer. They're useful for wound healing and healing at certain times of our life. So it's not like they're there for a reason. What we know is that they're there through our whole life at a certain amount. So, if you look at senescent cells in time, they should be kind of steady and slowly increasing. And as long as it's at a certain amount, our immune system can clear them, no problem. And they're, no problem. What happens is, as they increase in number, they hit a threshold. And beyond that threshold, then our immune system can't clear them. And then they rise really quickly. So if you look at there's a lot of, the FDA want to approve a drug, for example, for treating old age. They don't call aging an illness in today's world. But if you really look at aging, you could make a claim that there are two types of aging. One is just that one, you wore out your body, right? Sort of like your car, if you don't put tires on there, the tires wear out. And that's just natural. If we overuse our joints too much, they might wear out, or certain things might wear out just from overuse. And that's normal wear and tear. But what happens with these senescent cells is it's sort of like a process gets instigated where then those senescent cells rise, and then the senescent cells themselves lead to a increased speed and severity of aging and the diseases associated with aging. So, for example, if it was your car and you had a big leak of acid from your battery, and it's leaking all over the hoses and destroying the hoses and corroding your engine, that's sort of like what the senescent cells are doing. It's not just normal wear and tear; it's actually actively causing a problem in the inside of you. And it does it in a few different ways, and that's probably a good thing to go over now. So, why are the senescent cells an issue? One, and why are they called zombie cells? Let's go over that for a second. They're called zombie cells because, again, they won't die. And two, they infect normal cells and turn them into the same zombie cells.
Right. So they are very much something out of a movie where they bite you and then that cell becomes infected, kind of thing.
Exactly. And still, in and of itself, that's not the biggest issue. What happens is, one, you get these cells that aren't really functioning as normal cells. Two, what the cells then do is they're not, the cells then aren't undergoing their normal cellular repair and cellular processes. So they're sort of taken offline. So, for example, in Alzheimer's disease, what we know is that these senescent cells are associated with those neurofibrillary tangles of Alzheimer's disease. Mm-hmm. But what they also do is when they infect the neighboring cells, they take a normal, healthy brain neuron and they incite that brain neuron to die. So they kill cells around them, and then those cells undergo apoptosis, or they become more of these senescent cells. Either one isn't good because you need healthy brain cells, right? Mm-hmm. The other thing that they do is, in research studies show that 30 to 70% of these senescent cells release harmful inflammatory cytokines and chemicals in the surrounding tissue that actually damage the tissue in the cells. So, for example, senescent cells are associated with herniated discs. So a lot of the pain and inflammation from disc herniations are the senescent cells and the chemicals that the senescent cells are releasing that are harming all of the muscles and nerves around there, causing the pain and inflammation of a, quote, herniated disc.
Right. So they're really rogue, out of control cells. And it sounds like we can handle a certain level, But then what happens, because they're multiplying and sort of affecting the cells around them, it is like Zombieland or any of those movies that we've seen. The bigger mass that you get, you've got less of your healthy cells to regulate, keep them in control, and you start to get an overpopulation of these senescent cells that then, I'm assuming, and as you said, they corrode and lead to disease and things like that, which takes me on to specifically, you mentioned it contributes to heart disease, diabetes, and kidney disease, which are the core sort of three diseases that we look at. Is there a mechanism behind each disease, or is it the same mechanism? And why is it certain diseases in some people and not others? Again, is that the senescent cells where they're multiplying, or just how our immune system is able to control that? And then is that just a genetic thing where you end up, say, this person X gets kidney disease from senescent cells and person B gets Alzheimer's sort of thing? Is there a correlation between that at all? I've sort of gone off topic with you there, but just how do they contribute to chronic disease?
Yeah, good question. I'll attempt to answer that. I'll do my best. A lot of this is in research, and that this is all active research now, of course. And that this whole talk should go on this. These are all active research. I mean, cutting edge research, but far from conclusive. The researchers are all like, please don't, they're all adamant that they need more trials on this. And, none of this is clinical advice. I'm not the physician for anybody out there right now. Just Fiona and I have a conversation about this. One way that they affect everything and cause disease is by actually lowering the amount of stem cells that you have. So they can take these normal healthy cells offline, including your stem cells. So for example, if you have heart disease, I saw one study showing something like, once you have advanced heart disease, approximately 70% of your stem cells are no longer viable because of the senescence. Wow. So then you can't renew yourself. So when I hear this also, and I also prescribe stem cells for people, I've had it myself, I'm like, oh, well, if you really want to do stem cells right, and you really want to do these cutting edge treatments right, you actually want to lower your senescent burden first. Otherwise, you're actually, so these are the things I think about, like, oh, okay, yeah. So if senescent cells are affecting stem cells, and hey, maybe we want to lower the senescent burden a little bit before giving people treatments around stem cells. I think that would be useful. To answer some more of what you're asking around the illness and disease and how it manifests, some scientists would argue that it's just a matter of age and timing, and that if anybody lived long enough, they just get all these diseases from the senescent cells, Fiona, if that makes sense. You might have the other way to look at it. So that's one, is just if you give enough time, almost everybody's going to get these. Two, there are different types of senescent cells in different areas of your body. So they're in the fat cells, different ones in the neurons. And I am not an expert there. I don't even know all the different ones, but there are different ones, and they respond to different types of treatments, and they are caused by different stimuli. So basically anything that we know that causes aging causes senescent cells. So anything that damages DNA or mitochondria. So we look at chemicals and pesticides, radiation, viruses, anything like that we know will cause damage to a cell will cause senescent cells. And again, they're in different lines. Now, so, for certain types of people, this is really interesting. So say, you had, and they're doing trials on this now, say if you had a leukemia and you had to get a certain type of radiation, but you only had to get it once, well, that radiation did damage some tissue, cause some senescent cells. But the good thing about that is, hey, you only had that stimulation once. And so if you kill those senescent cells, you might be sort of cured from that for a long period of time. Now, if you get senescent cells just because you live in our modern world filled with chemicals and toxins and pesticides and all the normal stuff, then when we're talking about treating it, it might be more like an ongoing treatment. But we're getting ahead of ourselves, and we'll come back to that in a minute. Of course, there are genetic predispositions to these to different things, but again, these are all things we're just working out and far from conclusive now. Yeah. So you also asked a very good question, Fiona, about how do you know if you have senescent cells? Well, here's the simple and dirty method. So basically, and I had this from COVID, and we can also talk about COVID and senescence because there's a lot of research there. So you might be familiar with this. I'm sure certain listeners will be familiar with this. Like you're healthy, everything's great until all of a sudden it's not. And all of a sudden you look in the mirror and like your age, like number of years and months, and all of a sudden everything is broken. Well, what happened? Well, many things happened, but those senescent cells hit that freaking exponential curve where they went from being just a little high to all of a sudden very high. Mm-hmm. And now they are releasing those chemicals, and they're damaging much more tissue everywhere. So that's one way to know it is just everything goes downhill very quickly once you overcome your immune system's ability to clear these from your system. In COVID is known to attack senescent cells, and it actually then increases the amount of senescent cells. So that's why it attacks the elderly, obese, those with dementia, because it's going after all those areas that are senesced and will increase senescence. So I had a massive increase in my senescence after I got COVID and then long COVID. Yeah. So
that makes sense.
Part of treating long COVID is looking at, is there some large burden of these senescent cells that can be treated, potentially that can bring it down. And I gave you the information on this Dr. Alan Green. Yeah, so Dr. Alan Green has a good website on this. Anybody out there listening, where he goes through a lot of the research on this, and he's actually giving a trial of different treatments for long COVID now, and I'm doing similar for different patients, and we'll go through some of those treatments too. But as far as how to know if you have this, there is no test clinically. Right. Even when you talk to the experts at Mayo Clinic, they're like, they only have a definitive test to identify the cells. There's no perfect test even for them. Right. So it's a very complex question. And this is definitely going to lead to challenges in making these treatments more out there, for everyone to use. If you guys want to find like the expert on this, it's Dr. James Kirkland. And he's got a lot of good YouTubes. His advice is clear. Don't take anything. He does have a lot of good clinical trials ongoing. The guy's a genius. There's a lot of really good research there. And he's identified all the senolytics using some computer model, which is very, very good. And he's identified prescriptions and, chemicals that aren't prescriptions. So some are FDA approved already, some are potential future FDA approvals, but then he's also found natural substances are already safe. So in the natural substances are already safe, quercetin, which fits along with the whole COVID narrative because it's used for that. A lot of people, that maybe is why it was working. I'm not sure if it helped against COVID, and I'm not supposed to say if it is or isn't, but I think a lot of people found it helped with some of the long COVID symptoms afterwards. So quercetin, which comes from the peels of like apples. Mm-hmm. And then there's
Doctor away. Now we know why.
Exactly right. Not mention the citrus pectin. There's also citrus pectin in apples, which is great, but also fisetin, which is highest in wild strawberries, but you can't get enough eating strawberries. So the fisetin and quercetin are the ones I've used the most. There are quite a few others I'm blanking on right now. Again, not a lot of conclusive data on them. If you have a couple, you can bring them up if you want to go for us. If you got it, do you have any that you've looked up at all?
No, I looked up the quercetin and but it's mixed with a drug, I think, was the major trial I think that Alan Green was using, and then the same with the strawberries. They were the major natural ones, and I think maybe NAC was a senolytic as well, but I didn't see a lot of research that was, because a lot of them, like you say, they fall into a grey zone of we think it works via mopping up senescent cells, so it's a senolytic, but we're not sure. A lot of them are the FDA drugs, which you would know far more about that than me. It was quercetin, which was the one that I saw the most studies had been done on.
Yeah, I think that one and the fisetin, and again, they're working on what Dr. Kirkland talks about is they're working on different cell lines, and this is the hard part. So when consumers ask me like, oh, should I take this or not? Like, Well, he makes it very clear. I mean, there's certain cell type. I mean, in a perfect world, we would be able to identify, yes, if you have senescent cells, which cell lines are senescent, so that then you can give the pinpoint treatment. So, for example, the prescription the main prescription that's being used is dasatinib or dasatinib. I don't know how to pronounce it. I hear different ways. It's actually FDA approved for leukemia.
Yes,
In which it's used daily for years, and people have very low side effects other than nausea and headaches. So it seems to be a very safe medication when used, even for chemotherapy. And it's not, your hair doesn't fall out. It's not like one of the really poisonous chemotherapy agents. So that one works on certain cell lines. When you add quercetin to that, it then acts on even more cell lines, if I remember Dr. Kirkland's research accurately. And so they did research on those combinations, and that's what Dr. Green recommends. So he uses the dasatinib with the quercetin for a lot of his clients. And Dr. Kirkland also came up with this, and I think this is definitely in line with what I do, is that he recommends that you just need to do the treatment in what's called a hit and run fashion. So because the senescent cells in general will take 2 to 6 weeks to reproduce. So you don't have, if you get the right treatment, you don't have to take it daily. You can take it infrequently. So you just hit it. And in their research studies, they show that even if just the senolytic hits the cells for even just a couple of hours, it'll kill them. So hit and run means a low dose very quickly, and then wait, 2, 4, 6, 8 weeks and come back and do it again. So there's different regimens. Dr. Green will give the dasatinib and quercetin in 100 milligrams of the dasatinib with the quercetin. I don't remember the quercetin dose he's using. I think it's 500 to 1,000 milligrams, or quercetin 2,000 milligrams. And then he'll do that every 2 weeks, or he'll do 2 days of that every 3 months. I thought, who the heck knows what's right? Again, there's no research on this and we don't know. So, I personally have taken these, and when I do, I've taken usually 2 days of dosing every 1 to 2 months, something like that.
Is there with the research with the hit and run, because I take quercetin every day, especially we're in spring season here in Australia, so I'm using it for allergies and other bits and pieces, and just as a general anti-inflammatory. Is it better to do it in a hit and run effect versus taking it all the time? Is there,
Dr. Kirkland thinks so, but he didn't give the why.
Right.
Yeah, I think mostly for toxicity reasons.
Okay. Which would make sense with the drug versus maybe the quercetin, huh?
Exactly. I think with the quercetin, I think you're fine taking that because it's so safe and it has such good research over long periods of time. But the downside to it is, and we don't, this isn't like quantified in the research, but what I've seen clinically is quercetin and fisetin by themselves, like minuscule effects.
Right. Okay. So
you
really
add those in with the dasatinib, bam, really big effects pretty quick. I've seen patients have just take 3 or 4 rounds of the dasatinib over 6 months with the quercetin or the fisetin and get pretty good results over that time.
And what do you, when you say results, what do you see, like the before and afters? What does that look like?
And this is where, and this is why I have a small group of patients, because I have to get to know them so I can follow what's working or not working for them. But, like good ones like memory loss, early stage memory loss before pre-dementia sort of symptoms.
Yeah.
And again, I have a colleague friend, Kat Toops, who just published one of a little pilot study showing with her work, she's reversing and preventing dementia and Alzheimer's. So that's just
the senolytic treatment.
No, not even using this, using other things that aren't even as strong as this. Hopefully we can get her and some of her next studies to add this in. The reason I'm bringing it up is because she does all these subtle level testing for her clinical trials where you're doing, cognitive testing and mental testing, doing, different things that are assessing, just the first things that go when you have dementia in a quantifiable measure. I don't have a large enough practice with a large enough staff to be able to do that. But if I did, those are the sort of things I would follow. What they follow in studies on animals are frailty indexes. You can Google what frailty indexes are. And Kat just told me these, so I remember. I apologize. I have a little cold. My memory's not perfect now. But frailty index, I know this is wrong, but I'll give you, for example, like you can walk a certain distance before you're winded. You can stand, there are certain indices which gerontologists use, just really down and dirty, simple clinical measurements that they know correlate with death actually for people. Once you're hit as you're elderly, if you can't like walk this many feet without winded, if you can't grip something for this long, they know that your odds of dying within the next few months is quite high.
Yeah.
So they do a lot of that, the frailty index testing, and they also do that on mice, I believe, when they're doing these senolytic trials.
That makes sense.
So the interesting thing about the senolytics is they have shown in animals, not in humans, but this is the really cool stuff. In animal models, if you lower the senescent burden, you prevent chronic lung fibrosis, emphysema, kidney disease, heart disease, osteoporosis, and even studies for dementia and Alzheimer's are coming out. So that's where it's really exciting and it looks to be very promising. The key again is, it's like you have to, these sort of treatments, you really have to get treated before you get a huge senescent burden.
And this is the thing, isn't it? It's been really proactive. I'm going to throw out a question there that I didn't pre-warn you about, but Klotho, do you think senescent cells, and because we know Klotho is such a major marker for kidney disease, do you think there's a correlation between senescence reducing the production of Klotho and maybe there's a mechanism there? You may not know. Again, my brain goes, well, we know Klotho is, if we could test that more effectively, we would get really early markers of kidney disease before it's happening. And I'm wondering whether a senescent burden going up is maybe something where Klotho gets reduced. I know that is with the
I think you're right there. I didn't look that up. I'd hesitate to say absolutely, but I would bet you they're very much correlated.
And then I go, maybe is that an early test that they can look at? Again, this is just how my brain goes. Yeah, whether that's something that we could look at. But yeah, wow. So it's definitely in the early stages. But, when I looked at, you gave me Dr. Alan Green and James Kirkland, I think it is, to look at. And
exactly. Yes.
Yeah, some of the studies are amazing and just what they're doing with some of these chronic diseases. And so it does give me hope long term that we've got other treatments. And like you said, the drug isn't toxic and you're using it for, look, you're only using it for a short amount of time, sort of like you say, with this hit and run effect. So you've suddenly got a way of using a treatment that maybe is a little toxic, but you're using it for such a short period of time that you're not going to have a chance to really accumulate. And if you're knocking off senescent cells using these things called senolytics, then, why wouldn't you, sort of thing? And then that brings me to the point of, is that something that people could just do as a prevention for chronic illness or to reduce aging? Is that something you could just pick up and go, look, I'm going to be a biohacker and I'm going to use the quercetin and the dasatinib combination as just a preventative? Or is that?
Absolutely. I'm sure people are going to be doing more and more of this. Absolutely. And it's all risk benefit. What's the risk of taking it? What's the potential benefit? What's the harm of that medication? I don't see a lot of harm there personally. I'm always hesitant, it's always the question is, do you really need it? And it might be that, even if you took 1 or 2 doses of these a year, you might even get huge benefit for patients, and that's the hard part now. In a perfect world, again, I'd have, in a perfect world, the doctor would have a clinic where you do all these subtle markers and measurements, and then you could do subtle things and sort of see, because the problem with clinical trials in mainstream medicine is they're not looking at subtle markers.
Right.
They're not trying to keep anyone healthy. They're just looking for disease markers. And so, yeah, if we could look at subtle markers, but true story. I mean, I just had a patient. I just got his organic acid test back, and I've been treating him with senolytics and rapamycin and a few other things for now a year. And I have his, and the organic acid test is a measure of your mitochondrial function and toxins and a lot of things like that. I just got his back. It looks like, I've never seen anything like this. He's almost, it's almost perfect. There is no abnormality on his entire, his whole mitochondrial function we've re-engineered. And I'm amazed. Like, oh, wow. So, if we look at, senescent cells are right in the middle, basically, it seems like, of all aging processes. So, first thing I think of is, okay, so if you're a listener and you can't get access to these things, what can you do? Well, all the other things that you recommend people doing and all the good things that are healthy are lowering your senescent burden. So don't get senescent cells in the first place by, detoxing, keeping your hormones balanced, keeping your mitochondria healthy, keeping your kidneys healthy, doing all the things that I'm sure you got on all your other podcasts is healthy. Those are all going to keep the senescent burden down. That's really what we want to do.
You read my mind. That was
as
my
long as they stay down, you're fine. It's when they hit a certain level, and then you hit a problem zone. The interesting thing about these senescent cells too, there's two things. One, they work at a distance. So meaning you can have senescent cells in one area of your body, and they will make others in other areas of your body grow. So it's not just a local effect, unfortunately. Right. So you can take senescent cells from an animal, transplant them into another animal, and they'll cause senescence locally and at a distance. And then the other interesting thing from studies is if you take those senescent cells from older animals and put them in younger animals, the younger animals will have all the illnesses of the older animal within a few weeks.
I saw that study. That was...
And that's even like on the frailty index. So they did that. So they get the mice who can't walk and they're just about to fall over and die. They give them the young mice. A few weeks later, same story. For your listeners, for kidneys, one of the reasons you're likely aware of this, Fiona, and I'm not sure if your listeners are, but they throw away a lot of kidneys that look healthy because they come from donors that are too old. Once they're at a certain age, why do they throw them out? They're throwing them out because they have too many senescent cells. And if the senescent cells are over a certain amount, a certain percentage, then they will contaminate the whole kidney and they'll lead to rapid senescence and other disease. So basically it'd be worse than no kidney if you implanted a high senescent kidney into a recipient.
That makes absolute sense.
Yeah, so they're screening that now. I think they're starting to screen more and more, learning how to do that, how to screen how many senescent cells are in the kidney. And in a perfect world, hey, if we could get that freaking kidney, put some senescent, just drop it in a tub of dasatinib and quercetin, do that a couple of times, pull it out, stick it in. I'm sure they're probably working on this right now because Dr. Kirkland works with the head brain the brainiacs of the transplant world.
Wow, okay.
I bet you they're working on these already because that's a very very important field right now. So everybody's kidneys are quickly.
Yeah. And just to sort of bring it back around in a circle, do you think we're seeing, years and years ago, we didn't live that long. We were living till 40s and 50s was old, generally because of hygiene and disease, but maybe that increased a senescent burden. Then suddenly we sort of started to live longer, but now we're living longer with chronic disease. So does senescent cells fit into that? Because, for me personally, I'm not interested in living a long time if I can't remember what I'm doing and someone has to wipe my bottom for me. That's not quality, right? So as far as longevity goes, great, but I've got some caveats on it. So, and do you think the increase of chronic disease is due to the cleaners that we're using and GMOs and, smoking and terrible high processed diets and things like that you were mentioning, the normal things that we do to keep people healthy? Is that attributing to this increased senescent cells or, yeah?
Absolutely. Yeah, absolutely. Yeah, anything that's damaging our cells, and anything and everything is leading to the more senescent cells. It's leading to, and then it's that zombie, a little bit more senescent and a lot more than too much. Then you got one illness, then you got one more illness. That's why, and I've always told patients this, and I didn't know why. I was like, illnesses they're like an avalanche and they get momentum. And when you get a certain amount of momentum, I mean, there's nothing anybody can do. And, and this is why. It's because once that burden gets so high, you really don't have much of a chance. And also once those cells are dead, so like if you had a lot of zombie cells and they kill off, they induce apoptosis in those healthy cells, then you've got a lot of blank space. So if you had Alzheimer's, you get a lot of dead neurons up there. Now there's not a lot, once you get to that point, what can you do if there's dead neurons there? So the key is really preventing these in the first place, or two, nipping them in the bud as soon as they first get there. Because once they really have the opportunity to damage and destroy a lot of healthy tissue, then again, once those stem cells are gone, if you got blank cells sitting there that are dead and your stem cells are gone too, then you're really out of options then. So that's really what we want to do in my field, is more and more like, this also gives us more impetus that this is why you really have to prevent. And be very active. I mean, I get my patients are telling me now, oh, my symptoms aren't too bad. Calm down, doctor. Like, I'm like telling people now, as soon as you get something, like, we want to take care of it right now, not next week, next month, next year, 5 years from now, because then those senescent cells are up there. You got more damage, you got issues. So, I'm of the super aggressive type these days. When people get an issue, let's try to take care of it very quickly.
Yeah, well, it makes sense. And it suddenly makes sense to me why there is such a correlation between heart disease, diabetes, and then on to kidney disease. I mean, we know obviously high blood pressure can damage the nephrons and things like that, but then I go, there must be a correlation between these senescent cells and those organs and the fibrotic processes that go on inside the kidneys. I'm sure it's not just the high blood pressure and the diabetes and the glucose, but also the senescent cells causing the cytokines.
Exactly. The cytokines, and right, these are the cytokine storm from COVID, so that's what everybody can relate to. That's what the cytokines are doing. They just make pain and, all kinds of unpleasant symptoms, we could say.
No, totally makes sense. Well, that was a really good coverage of senescent cells. Anything you want to add to that to tie it all up or to finish it?
There's one other senolytic which has really great research. It's called FOXO4-DRI. That's a great one. That is in drug discovery now. I'm not sure what it was discovered at the Buck Institute. Yeah. Now director of that's at the NUS in Singapore. I forget his name right now, but they have a lot of really good YouTube videos on senescence and senolytics. The FOXO4-DRI works on the P53 pathway, which is related to cancer. So I've used that one, and I think that one will likely have good positive clinical trials around cancer prevention and or cancer treatment. That'd be my guess on that one. Yeah.
Does that one fall under a peptide? Because I always find it on the peptide websites. Yeah.
It falls under a peptide and is injectable. And the interesting thing about that one and the dasatinib, interesting caveat. I mean, okay, so senescent cells pretty much fit under what how do you pronounce him? KOCH, the cock postulates, whatever you pronounce his name.
Oh, yeah.
Basically, as an infection. So I'm not
Yes.
saying senescent cells are an infection, but if you take it from an old animal, put it in a new one, they get the disease. And the interesting thing also, when you talk to Dr. Kirkland, listen to him, he's talking about how it fulfills those postulates too in his, but he doesn't talk about it as an infection. It's interesting. I'm bringing it up because when I treat a lot of infections, people get what's called a Herxheimer or die-off reaction and feel worse. Well, guess what? Me and my doctor colleagues, I mean, a lot of doctors are always the ones who's tried these on themselves first. So we all talk to each other about it, and they're like, hey, did you notice like the first time you did that, you felt pretty horrible afterwards? Yeah. So a lot of the first time or two or three you take these, you often will get a die-off reaction. Like for mine was like a horrible migraine, but you can get flu-like symptoms, migraine symptoms, things like that for a day or two after taking these the first time. But then after you take them subsequently, the symptoms go way down. Yeah.
I did hear this with the FOXO4 DRI. I've had a few people like you. I'm the same. I try everything on myself. Like you should see the amount of peptides floating around on my desk in front of me right now. You know, sneaking things in through customs into Australia. I've got Cortexin sitting in front of me, but FOXO4 DRI is what I've heard a lot of people are herxing off. So that makes sense because it's mopping up, right? So then you stimulate almost your immune system to clear the burden, so you get an immune response, hence fever, headaches, and all of those sort of things. And that is just an upregulation of the immune system doing what it needs to do. So
exactly. Yeah,
that makes sense. Perfect. All right. Anything else you wanted to add to any of that, Dr. Camp?
I don't think so. I hope that was useful. I know it's kind of, theoretical and philosophical in some ways and exciting in others, but, yeah. So I hope it was useful.
No, definitely useful. I think our listeners, we're always looking for the latest and the new sort of stuff. I think people I know I feel let down by modern medicine and there's gaps, some treatments, having MS myself, some treatments work for some people and then they do not. And I fall into it does not. But these kind of treatments, this is where I get excited because I do think there are some amazing things. And especially with peptides and things like that, drug companies take a little longer to get their handle on them, which means we can still be using them and they're a little bit more natural with less side effects. But the dasatinib and only using that, every now and then, you go, well, that's actually healthier than bombing someone with chemicals with big side effects. So I think it's really exciting and it gives people just the chance to think outside the box a little bit as well and see if there's other stuff floating around if more traditional treatments haven't worked. But I'm excited because so for anyone listening and who appreciates Dr. Morgan Camp's brain like I do, we're going to do a whole different series on different things. So we're going to cover peptides and the 7 pillars of longevity, and there's a whole pile of conversations that we're going to cover here in the next coming weeks and months because Dr. Camp has been very generous with his time. So stay tuned. He'll definitely be back and we're going to be covering more and more topics. So if you want to know more about Dr. Morgan Camp or reach out to him, I'll put his website below. If you just Google his name, Dr. Morgan Camp, his website will come up and you'll see him there and you can reach out there. I know he's putting together some great programs to be able to support more people and do some online stuff. So there's a lot of different ways that you can work with him. If there's questions or topics that you want he or I to cover next time, put them in the comments below. I do look at that. If you want to know more about what we do, head to www.kidneycoach.com and remember to hit subscribe, and that way you'll get notified the next time Dr. Camp and I jump on and do one of these things. So, Dr. Camp, thank you again for your time and your generosity with everything. I'm always very grateful to have you on here. And for everyone listening, thanks for being part of our community. We hope you found this useful, and we will be back again with more cutting edge breaking information because this is what I'm passionate about and I find very exciting. So it's always nice to have similar brains as excited as I am. So thanks again, and we'll see you next time, Dr. Camp. Again, I really appreciate you and your time and what you're doing in the world. You need to keep doing that. You're a shining star.
Thank you, Fiona. Thank you for your good work. So appreciate you. Thank you.
You too. Bye, everyone.